Hello and welcome to our webinar with Professor Richard Grol from the Bound University, Nijmegen, Academic Medical Center in the Netherlands. Professor Grol is a director of the Scientific Institute for Quality of Healthcare and a guest lecturer with many distinguished universities around Europe. He has written over 300 peer-reviewed papers and published 20 books. One of Professor Grol's books is coming out on the 1st of June. Today, Professor will be talking about improving patient safety from analysis to action and practice. The presentation will take approximately 45 minutes, after which you'll have 10-15 minutes to ask Professor Grol questions. To ask a question, please type it in your control panel. On behalf of ISQua, I hope you will enjoy the session. Over to you, Professor Grol.
Thank you very much. Dear colleagues, a very welcome to this webinar, and great that you are there. This is what I'm going to do. I will start with the presentation of a safety crisis that we had in our own academic hospital. And next I will present a 6-point plan for improving for hospitals to work on patient safety improvement. And particularly focusing on actions that go beyond the recording and analyzing of incidents. So let me start with the first slide. I worked for almost 35 years at the Academic Medical Center in Nijmegen. It's one of the largest hospitals in the Netherlands. And we had a major safety crisis in 2005. And I can tell you that this was shocking for all of us, although also in the end it was very educational. And I would like to present some of the lessons we learned from that safety crisis. It all started in September 2005. There was an internal email by an anesthesiologist that was leaked to the local newspaper, and you can read it here. Yesterday we had a meeting on the care pathway for cardiothoracic surgery. Data were presented from the National Intensive Care Database, and these showed that our health center did not operate more serious patients, but that we had a mortality rate twice as high as the rest of the Netherlands. Also the reoperations because of bleedings were much higher. This is a very serious problem. So this email started a whole range of activities. First of all, the CEO of the academic hospital said this can't be true. So he was actually denying the problem. But soon, when the real data came out, a mortality rate of almost 7% compared to less than 3% nationally, patients were skipping operations, referrals were not referring anymore. There were a lot of actions started at that point, internal and external investigations, and actually they all showed they were very, very critical about performance. They showed that record keeping was not okay. There was no collaboration between the different wards and disciplines. There was no teamwork. There was a very negative attitude of the doctors. There was no leadership. There was no quality control. So the authorities decided to close the center for 6 months, and then everything happened. The executive board, the director of the heart center, the leaders of the medical staff, all were forced to quit. And this started a series of innovations. First of all, a new executive board for the Academic Medical Center, a new director of the heart center, new clinical leaders, new surgeons, a complete redesign of the surgery process, more collaboration between the different involved disciplines, a new quality and safety policies for the whole center, rigorous clinical audits, etc., etc. And what you can see now, that the mortality rates are in 2010, but also 2011, I show you in a minute, are around 1%, and a similar reduction in complications, readmissions, etc. So what you will see on the next slide are figures about predicted mortality and actual mortality. And you see them over the years. So on the basis of the severity of the patients, the predicted mortality in 2011 was almost 9%, while the actual mortality was 1.3%, actually the lowest score for mortality of this type of surgery in the Netherlands. So I hope that you agree with me that this is quite surprising. And I will skip now one slide. Let me just see, yeah, skip this slide. You can read it later on. But I particularly would like to ask you to think with me about why this major improvement in heart surgery safety, and particularly what external factors have contributed to this major improvement and what internal, so hospital and ward related factors contribute to this improvement. So while I'm talking, you may formulate hypotheses for yourself, because then you will see that this is quite a complicated mix of incentives in order to get improvement done. And let me first start with external factors, because what you can see when we analyze this case, we saw that both external factors and internal factors were crucially important. And I start with the external factors, and they probably, you need them sometimes in order to force change. First of all, very important was the closing of the center by the inspectorate. So this was quite shocking for everybody. But also the public reporting about the problem in the media. Actually, this was a case of public shaming and had a lot of damage to the reputation, not only of the heart center, but of the whole academic medical center. And then there was the influence of patients and referrers. Patients skipped operations, there were less referrals for operations. So all these contributed to something that was not there before, a sense of urgency among all the people involved, the leaders, the physicians, the board of trustees, and particularly also we had data on performance, but they were not trusted, they were not used, and when they really analyzed and saw the data and saw that these were reliable data, this also increased the sense of urgency among almost everybody. So these were the external factors. Let me go to the internal factors. Actually, we had, after this serious crisis, we had a whole series of activities in order to get the primary care process on a high level of quality. And when we analyze now what is happening there in the heart center that keeps the mortality rates and the complication rates at a very low level, I think these factors contribute to that. And read them carefully because they will come back in my presentation. First of all, reliable data. You need to have good clinical data for continuous reflection. And at the heart center, there's one physician responsible for organizing these data. There's a data manager. So there are data available all the time. Then care pathways and care processes that are completely standardized and controlled. Every action is described and no one is allowed to deviate from that. It's continuously controlled. Then there's a leader committed to quality and safety who is a role model but also very much in charge and in control. Then there are committed professionals who now know how to keep the quality on a high level, and it's actually the case that if you don't work in that system, don't want to work in that system, you can't work there. there's now intensive collaboration between all the disciplines and wards involved, with a shared record and everything. With weekly meetings, teams with skilled nurses who have their own standardized procedures, a culture of mutual trust, respect and openness. So everything is discussed every weekday. And so every week there's a meeting of all the people involved of the center in order to discuss incidents, problems, etc. And finally, hospital-wide quality policies supporting the continuous improvements, also at the level of the heart center. I don't go into detail, but you see here a number of crucial elements of a plan that you need for continuous improvement. I go to the next slide. Yeah. First, back to the data, and I think these are data. Sorry, I need to go one back. The slide is not working well here. Let me check if I can do it. You see here data on safety problems in hospitals in the Netherlands. And they are probably similar to the data in other countries. In we had a very good audit on adverse events. It showed 6% of hospital patients encounter an adverse event, and 40% of these are avoidable. We have almost 2,000 avoidable deaths per year in our 100 hospitals. 40,000 people admitted to hospital per year because of medication errors. Almost 7% of the patients in hospitals get an infection there. There's a lot of extra cost. We estimate that the extra cost of unsafe care are about 2 billion euro per year for 100 hospitals. A few years ago we had a national safety plan focusing on 50% reduction in adverse events, but mostly focusing on reporting and analyzing incidents. And we know now that the 50% reduction we haven't achieved so far. So the question is then, what can you do to improve safety? What you see here are the results of a systematic review done a few years ago by one of the researchers in our center. And he made a distinction between the impacts of reporting and follow-up, analysis of adverse events, and further interventions to improve safety. And you see the results here. Reporting and follow-up adverse events have positive effects on the quality of reporting and the number of incidents reported, but no effect on the safety of care. The effects of the analysis of adverse events with different measures is yet unclear. And if you look at the studies on improving safety, for instance, medication safety, falls, etc., it's very difficult to make conclusions from that. The World Alliance for Patient Safety in 2008 said most investments at the moment are done in measuring and reporting adverse events, and regrettably little in improving safety. So the question is, what can we do in improving safety? And this is not too easy, because if you look at it, you see that the causes of unsafe care are very diverse. And that means that also improvement needs to take into account all these diversity. You have problems at the causes at the level of the patient related to knowledge, experiences, multimorbidity, language problems, the professional knowledge, skills, attitudes, stress, addiction, at the level of the team, in terms of collaboration, handovers, leadership, culture at the ward, at the level of the organization, also in the leadership, the governance, the budget, the processes, the workload, and finally in the economic, legal and cultural context. So you need to work on all these levels to be effective. But I don't want to make it too complicated. So what I've done is to select 6 points in an improvement plan that go beyond measuring and analyzing adverse events. And you see them here: continuous monitoring of real-time data, standardization, checklist, control, improved coordination and teamwork, involving patients in safety improvement, changing professional attitude, better leadership for safety. And then I will conclude that you need to work at different levels and have these different actions at different levels, both at the level of patient, professional teams, organization, boards, etc. So that's what I'm going to do. I will briefly go into each of these 6 points. And let me start with the first one: data and feedback systems. I think we know from the literature, very good study done in JAMA in 2006, that professionals overestimate their own performance, and that you need good data, good, reliable, relevant data to convince professionals and to motivate them to work on improvement. From different systematic reviews now, we know that feedback can be effective, but only in case when the data are very recent and when you have real-time monitoring and feedback and very recent and very quick feedback, so that the professionals know what you're talking about. The second is advice, not only feedback but also advice on how to improve care, and rehearsal, regular feedback. Very important is that these data are trusted and seen as relevant by the professionals, and mostly they are seen as relevant and trusted if they have collected themselves and are about key issues in their clinical work. And finally, if the feedback is not only given to an individual but is embedded in normal clinical audits, peer review, discussions in the teams. We know now that setting up this data and feedback systems is not easy, and most of the time you need support by experts in order to set them up. One example, what you see more and more popular are clinical registries. And this is an example. There was a report in 2011 of the Society for Cardiothoracic Surgery in the United Kingdom. And what they showed was what they do for many, many years is monitoring and public reporting of mortality rates, complication rates, etc. And they claim that over the year that there was a 50% reduction in risk-adjusted mortality rates for this type of surgery, with a substantial cost reduction. I don't know whether this is only the feedback or also the additional measures taken, but it shows how this type of registry can take place in continuous improvement of safety. Sorry, right here. We have a similar type of registry. Yeah. Yeah. We have a similar type of registry now in the Netherlands around colon and rectum cancer surgery. This was started 3 years ago, and these data are collected by all the 100 hospitals that do the surgery. They are summarized and given as feedback. And you see, for instance, here that the post-operative mortality for colon surgery reduced from 4.7 to 4.2 in between 2009 and 2010. Or the pre-operative screening increased with 10% in 2 years. So we hope that this type of information will really be a help to make progress in this field. Okay, I come to the next, the second issue, how to involve patients in improving safety. I will be very brief about that because there's a wide range of instruments and measures you could take. But in any case, it would be important for a hospital to have a plan or a program to involve patients, and particularly to that includes enhancing the knowledge of patients about what can you expect of your treatment, that you help patients to observe what happens during their treatment, that you involve them in decisions about the management of their problem and use decision aids. I will give an example. How they could give feedback to care providers in a positive and critical way, and how to involve family or buddies during, particularly in complicated situations. So a program that involves these type of activities. How could you prepare patients in getting more safer when they are in the hospital? Let me give you one example of an there's an example of involving of patients in decisions, and this is, let's say, a decision aids that aims for more safety in the case of IVF. In IVF there's an important decision to make, and patients can be involved in that, and that is the decision between placing back one embryo per cycle or 2 embryos per cycle. And with 2 embryos per cycle there's a higher risk of pregnancy, but there are also much more risks of complications, both for the mother and the child. For instance, the risk of a death of the baby is 5 in 100 when you place back 2 embryos, and this is only 1 in 100 when you place 1 embryo back. Of course, the chances of pregnancy are smaller when you place 1 embryo per cycle back. We have put this forward in an experiment described in published in the BMJ, and it showed then when people got this decision aid and they got some help by both the physician and the nurse, they were much more selecting 1 embryo, so the more safe option. And I think there are many decision aids now that can help patients to make more safer decisions during their care process. I go to the third, sorry, I need to go back. I go to the third element of the 6-point plan, and that has to do with better coordination in order to have safer care. And the only thing I will do here is just put on one slide some systematic reviews and Cochrane reviews, etc. Actually all saying the same, more or less. First of all, a review of 22 systematic reviews on integrated and coordinated care for patients with heart failure, diabetes, depression, etc. is related to better quality, better patient outcomes and lower cost. The next was a report written by John Overett for the Health Foundation. What he is saying is many adverse events are actually caused by incomplete coordination, and there is strong evidence for the effect of, for instance, disease management, multidisciplinary teams, coordinated discharge planning, and post-discharge care for chronic patients. And finally, a Cochrane review on the effect of integrated care pathways with 20 studies, showing an impact on the complication rates, on the length of stay, and the cost for hospitals. Let me then zoom in a little bit and focus then in that coordination process on standardization and control. maybe you know the story of Odysseus and the sirens. The sirens were half gods, they were half human and half bird. And what they did was seducing seamen with their singing. But if the seamen came too close to the shore, they ran the risk of a shipwreck and dying. So Odysseus wanted to hear that singing, and therefore he asked his sailors to tie him to the mast and to fill their own ears with wax so that they couldn't hear anything. So they came close to the shore. Odysseus wanted to go nearer, but the seamen couldn't hear him, so they came by safely. So and this way they survived. So actually the lesson from that is that sometimes medical professionals, care providers need to tie themselves to the mast to survive in a world full of seductions. That brings me to the next, an author that you probably all know by now. Atul Gawande wrote a very nice book on checklist, but crucial in this book is this message. What he is saying is healthcare is actually managing of extreme complexity. Healthcare is too complex to leave to the control and the decisions of individual professionals. And that's not because they have the wrong attitude. The problem is that human memory and attention that you need all the time in this complex care is fallible. So you need other people and you need instruments to help you to get in this complex, unsafe environment. And therefore you should use teamwork, control and checklist. And he gives the example of the intensive care. An average patient on the intensive care needs 178 actions per day. And although even when everybody is working very hard, there are errors in 1 to 2%. And so you need a backup for that. And to give a few examples of this importance of checklists and control, this is one systematic review, Cochrane review, on interventions to reduce antibiotic use in hospitals. And we all now know how crucially important it is to be very conservative with antibiotics because of all types of resistance problems. These studies showed that in most studies there was a significant effect on antibiotic use, infection and clinical outcomes because of the interventions, but restrictive methods, for instance, authorization by a colleague of use of strict indications or automatic stop orders before you could prescribe an antibiotic, are much more effective than educational methods. And we now use most of the time educational methods. That's one example. And the second is surgery. We also know that most adverse events in surgery are happening in surgery. And mostly these are infections and bleedings. So how to prevent that? And here you see the study in the New England Journal of Medicine on the WHO checklist in 8 hospitals in 8 countries, where you have this surgical safety checklist with 19 killer items before you start with the operation, at the moment the operation actually starts, and after the operation, sign in, time out, sign out. And it shows a large reduction, actually a 50% reduction of mortality and a large reduction of complication. We had a similar study also in the New England Journal of Medicine in the Netherlands with a more or less similar checklist, a little bit different, and with similar results. So I think they can work very effective. However, if you look at the implementation of the checklist, you also see a number of problems. It's an article in the BMJ. First of all, that many nurses are embarrassed because when they have to do this, reading out loud, time-out moments, they are embarrassed. They don't feel comfortable. Often they don't have the right training for that, and the hierarchy in the operation room doesn't allow you to do this, to use this checklist. So we need to do something about that. And I would like to give this other example of reducing central line catheter infection at the intensive care. I think a very famous study, also presented in the New England Journal of Medicine, a control study in the state of Michigan hospitals, 50 intensive care wards, with a simple checklist to prevent central line infections, actually a bundle with a checklist, with a reduction of 66% of infections. And they claim the saving of 2,000 lives and preventing substantial extra costs. However, some years later, the key author, Peter Pronovost, he wrote a book about it, and what you could say from his conclusions was the interpretation of these results are standardization and control of performance is indeed effective, but only in case of support by the leaders. So if someone, a nurse for instance, does it and the leader is not behind him or her, it won't work. And you need improved teamwork, and you need physicians who accept control by nurses. So this is not an easy thing to do, but crucially important. And that brings me on actually the fourth point in the plan, work on teamwork, team training, etc. I show here a slide from a book of Judy Hofer-Gittel, High Performance in Healthcare. And what she is describing, what she is mentioning, is the concept of relational coordination. And what she means by that is not that you are good friends, but that you have frequent high-quality communication, that you have shared goals, shared knowledge, and mutual respect. And that's what you need to work on. She shows that this had a significant positive impact on clinical performance in operations. The other aspect of this is the crucial role of nurses. We know now also from systematic reviews that in many cases the nurse can, for specific actions, for specific performance, the nurse can deliver the same quality of care and sometimes with more satisfaction. But particularly in the team, within the teamwork on quality and safety, nurses are most of the time much more eager, but also much more disciplined in doing the checklist. You may have heard of this case, the Hudson River Hero. That was this airplane that had to land in the Hudson River, and they managed to, the pilot managed to get the plane down safely, and all the passengers were saved. And the Captain Sullenberger, became very famous as the Hudson River Hero. But actually, also in his explanations, we should speak about Hudson River teamwork, because an analysis of this case showed that not only the experienced pilot and his leadership, but also the strict use of checklists and procedures and the optimal teamwork of the crew on the whole contributed to this safe outcome. And this brings me to the next issue. I think half a year ago or so, I was in the US and I was reading the US Today, and there was an article by the chair of the American Board of Internal Medicine, and this was related to the fact that they were planning to stop the world famous series Dr. House. And what he was writing, and I found this, yeah, I can endorse that. What he was writing was, we need physicians who are smart, well-trained, innovative, intensely focused on delivering the best care to patients, and who can play well with others. While Dr. House had many of these skills, the teamwork part was his fatal flaw. And if he worked for me, I would have fired him. So rest in peace, Dr. House. So he's making an important point, I think, because that's point 5 on our plan. You need to have deliberate actions focusing on a new type of professional in your hospitals, also in primary care. Improving quality and safety in healthcare demands a new type of professional attitude. Professionals who use data for critical reflection on their own performance. Professionals who are willing to be accountable to others, both to their colleagues but also to society at large, who accept control by others, even when it is a nurse, in case of a doctor, or nurses among themselves. Becoming a team worker and collaborator, involving patients in decisions, admitting and communicating mistakes and incidents, and being skilled in systematically improving care. And I think that's a long way to go for many professionals in many countries. In this slide, you see a study done in the United States and United Kingdom 2 years ago, where they had questionnaires to many doctors in many different disciplines, showing something about their professional values. And I have a few outcomes here. For instance, doctors should participate in peer review of quality of colleagues, the percentage of agree. Doctors should report incompetent colleagues. Doctors should disclose medical errors to affected patients. Doctors should undergo periodic recertification examinations. You see the scores, a lot of improvement possible there, and maybe there's still a lot of social desirable answers in that. So one of the things to do is including the topic of quality and safety improvement both in the undergraduate and postgraduate curriculum of clinicians, because many professionals think that they learn about quality improvement in their normal work, but that's not the case. It's concerned with new knowledge, skills, attitudes, routines, improvement knowledge, and it's naive to expect that you can master these competencies without appropriate education. So particularly the training by role models in teaching practices for young doctors is crucially important. And what you can also do, of course, and you see it happening in some medical schools now in the United States and Canada, mini interviews to test the skills to communicate with patients and collaboration in teams just before you are recruited to become a doctor, a specialist in a hospital. I come to my last point, and that has to do with leadership. What you see here is a football field, and you would agree with me that even when you have the right procedures, the right professionals, the checklist, the coordination and everything, and they let you play on this field, it will be disastrous. So leadership, actually the 6th point on the plan, is another crucial element. What you need for all of this is leaders who create a context for transparency, who stimulate professional development, who stimulate the use of checklists, who stimulate the use of patient involvement, etc. So you need leaders, and you need to train them, leaders who make quality and safety to their absolute priority, both at the level of wards, but also at the level of the CEO and the whole board, who are a role model, who know what they are talking about, who are competent, who introduce long-term policies, who introduce a 6-point plan. We had this thesis in the Netherlands showing that when executive boards stimulated quality improvement and the doctors perceived an active role by the board, that they were also more actively involved in quality and safety improvement activities. So crucial important. It's the same is shown in some other studies in England and the United States. And I would like to end my lecture now with one study also showing this. And this is about reduction of hospital infections and particularly the hand hygiene. If we go through the literature, we see that there's enormous literature about both the necessity of good hand hygiene, the guidelines on good hand hygiene, and the poor adherence to guidelines on hand hygiene. Most of the time we see figures below 50%. And I would like to show you this study, a huge randomized control study on improving hand hygiene by nurses in 3 hospitals at 67 wards. And this study compared the impact of 2 approaches on adherence to hand hygiene guidelines. First of all, a state-of-the-art approach, and this is the normal approach, and we already know that this can be effective, with feedback on data, posters, education, alcohol rub in your pockets or at the bedside, etc. And another approach that is a state-of-the-art approach plus a team and leadership training, particularly focusing on the team on setting targets, on speaking to each other when they are not compliant to the guidelines, and a leadership training to setting priorities, to supporting their staff, to account on the figures to outside. And what you see here is that the state-of-the-art approach already had a very large impact, more than 20%, but combined with a team and leadership training at almost double effect, almost 40% improvement. With an impact on infections, more than 1% less infections in the extended approach, and an impact on the cost, less cost per ward in the extended approach. And what this researcher from our center did was also looking at the variation in change. Because if you look at all the 67 wards, you saw that some wards hardly had any change, while others had more than 70% change. And she analyzed which factors, team factors and leadership factors, were crucially important. And as team factors, she found, first of all, the data and feedback to the wards about about the hand hygiene performance, the mutual control on not following guidelines, and the mutual support in order to improve routines in hand hygiene. And as leadership factors, better hand hygiene as a priority set for the whole ward and team, accounting about hand hygiene performance to the hospital leaders also asking for that, and leaders who motivate the team to perform better. And this brings me to the end of my lecture in 3/4 of an hour. What I wanted to show to you was a 6-point plan that goes for patient safety improvement. And actually what I would like to suggest for you is to do a little bit for each of these 6 points. There's a huge range of possible instruments, interventions, etc. to be used, but it's not feasible to do them all. So I would urge you to select for each of these 6 aspects to select something that you work on. Leadership enhancement, improving professional attitude, the new professional, involving the patient, for instance, safety training or decision aids, improved teamwork, checklists, coordination in care pathways, and particularly also real-time data, systems for monitoring care and feedback, and integrating these safety actions at different levels. Because because single isolated actions are often not very effective. You need to integrate actions at all levels. And that brings me to the end. So safety improvement is a real challenge. And you need to have a well-designed approach, a good plan to be successful. And this book that will be published at the 1st of June 2013 by Wiley Blackwell, I think will offer such an approach. So that's for now. I wish you success with your plans, and if you want, let me know your successes and failures. But in any case, thank you very much for listening.
Thank you very much, Professor Grol. That was very interesting. And I already got a couple of emails from some of the attendees just to thank you for the great presentation. Now we will take a few questions. I have a message from Dina Barudi. Many thanks. Do you think that closing a department due to bad results is a wise solution to reach improvement? Congratulations for your excellent internal factors in achieving safety. In my experience, is that the element of standardization is the most difficult. Can you give me a clue for success? Especially when hierarchy, as you already said, and do you really believe that physician will accept nurses' control? In my part of the world, Saudi Arabia, by the way, I'm an anesthesiologist. So over to you, Professor Grol.
Sorry, shall I answer this question now?
Please.
Yeah, I'm going to answer this question now. Thank you very much for this question. I think that actually this part of the whole plan is probably the most complicated. When I did my own projects, I'm retired now, but I'm still involved in many hospitals, on boards, etc., and speak a lot to people from hospitals. They all the time present this as the most difficult problem. And I also think that this is not a problem that you can take away within a few months or so. This is really hard work for a very long time. But in order to make progress, I think there need to be actions also to go to level down this hierarchy and to involve physicians really in this type of issues. You need to work on different levels. I think leaders, the CEO, the board, need to be very, very clear about their vision on this and what they want from teamwork, hierarchy, checklist, and how physicians need to deal with that. So this is a constant discussion with the, let's say, the medical leaders from the hospitals. So involving the medical leaders in that is also a crucial element. So the board of the medical leadership, of the board of the medical staff in the hospitals need to address this issue. Then I think you need education. You need education in which you use good data where you show that improvement on issues that they think are really important for patient care is indeed necessary. So data are crucially important to convince people. Also that they need to do different things. You also need to educate young doctors into a new attitude to teamwork, to hierarchy, etc. So I think this demands a whole plan and continuous effort. And I know that this is difficult, but I can't make it more beautiful for you.
That's great. Thank you very much. And Gina Barodi also thanks you for your response. I also have a question or request from Professor Andreas Becker. He thanks you very much for your presentation, and he said that you stepped over one of the first slides in the beginning with some data, and he was asking whether you would like to go back into it perhaps and explain it, please. So I'll try and find you this slide. Okay.
Which?
Looking at the same slide. I think.
Okay, let me say a few words about these data. What you actually see is here is a so-called custom score, and the custom score is based on a relation between the people you might expect that would die from the hospital and that you would expect to die, and the actual mortality rate, and that gives you the possibility to express a rate of the number of lives saved. And what you see here is the black line is actually the line under which, that's the red line, that is the number of patients that actually were saved, although you could expect that they had a high risk of dying. So that's what this figure says. And okay, I didn't want to discuss it because it's a little bit technical.
That's great. Thank you very much for that. We don't seem to have any more questions. So I just, on behalf of the attendees and ISQua, I would like to thank you, Professor Grol, for this wonderful presentation. The recording of the presentation and slides will be available online at www.isqua.org very shortly. And thank you all for attending ISQua's webinar, and I hope to see you at the next one. Goodbye.
Okay, thank you. Jolante? Hello.
Hi.